like friends. Before I start that, I just have one slide about MD Anderson and what are they trying to do globally. So MD Anderson is a cancer center in Houston, in Texas, and it's trying to make an impact globally by basically influencing and working with a limited number of countries, of which Indonesia is one of those. I would say probably their main partner is Indonesia. And so there's a MD Anderson has signed a memorandum of understanding with the Ministry of Health here. That's way above my pay grade, so I don't really know the details of that, but it means that I'm in a position to try to be here today for one thing, and then to see if there's anything that we can do together. Okay, so where's AI taking us? So first, we need to think, when we think about what AI is going to do, we need to think about the level of automation and where is AI going to fit in. And you can think of automation in these different levels, going from zero, where there's no automation. So that's, like the old days with we were just talking about it yesterday with hand calculations and this sort of stuff. And then through like a level one is where you've got something doing things like a 3D dose calculation. So it's doing single tasks. So you press the button, it does the dose calculation. AI is going to be doing dose calculations, by the way. But it's not really that level, that sort of low level of automation is not going to affect our lives that much, because it's just like what we have in our planning systems and what have you right now. Once, however, you get to level two, it's where you've got multiple tasks. So it could be like doing your plan optimization followed by the dose calculation. So it's really starting to take over some of the human responsibilities in the task. But really where we're heading in the next year or two, where we're there in many cases, is what we've called level 3 automation, which is where an entire process is automated. And so an example of that would be where you've really got, you take the CT scan of the patient, you then put that into your planning system, give the prescription, and then the AI takes over and does all of the contouring, all of the planning, and then presents the results to you at the end for you to look at and decide if that's what you want for your particular patient. That's where we're going. And I think in the next few years, we're going to see that in most of the planning systems for a lot of the tasks, especially for some of the simpler ones like prostate and things like that. Level 4, by the way, is really, there's no human in the loop. And that's where I think we're probably like 20, 30 years, if ever, from that, because we still need a lot of people. And that's something I should have said on this first slide. This is why all these pictures of the people are here. These are the different teams that we work with. But even when AI is here and is really helping us with all these different things, the key component of all of this is going to be the people. And I'll come back to that theme later. And so of course, this is a test now. So it's not just talk. There really are, AI is really here. And so we use a lot of these tools in our own clinic already. Here we have an upper abdomen CT scan, one of which is being contoured by a person in the clinic. One of them has been done by a computer. This is a tool that we developed, but it's in use in our own clinic. We use it, I think it's on about 30 to 40 patients a month. We're using this for the physician. We haven't done a formal timing study, but the physicians tell me it saves them 30 to 40 minutes per patient. So which is the computer one? Confident. Why do you say that? You're right. Wow. I've never had someone answer so confidently. So you're right. But, the point, of course, is that they're basically the same. There's no, the clue is that there's no overlap, like you said. And humans tend to not care about that so much when they're drawing and they're doing it quicker. But the point is that they're the same, and you could have used either of these for the clinic. In fact, the one on the right was used clinically, and this is just done retrospectively. So that's normal tissues. And I would say in terms of AI, normal tissue contouring is here, it's done. If it's not available in our clinical practice, it's just because we don't have the software yet, but the technology is there and it's very doable. The next thing is the tumor. So here we have a head and neck patient where we have which of these was drawn by the computer. So we've got the red one is clearly just the PET delineation, but then we've got the green and the blue, Are you going to be as confident this time? Which is the computer for the contouring? Somebody has to answer something. You can't tell. You can't tell. You're not supposed to be able to tell. So in this case, the green was the clinical and the blue is the automatic. But again, the point is really, if you can imagine you add a PTV margin to that, there's really no difference in those. And this is work done by somebody in our team. It's not quite ready for prime time. It's not reliable enough. Not like the normal tissues tend to be very reliable. The GTVs, because they're so different from patient to patient, not quite reliable enough. But this will be with us in the next few years. And this auto contouring is really going to save us a lot of time. So when we're doing manual contouring for all the normal tissues in the head and neck region, it takes about 50 minutes if you do all of that by hand. If you do it automatically, we're still doing some editing. You could argue the editing isn't really needed, but we are still doing it. It takes about 10 minutes. So we're saving 40 minutes per patient, which really helps us with our throughput. Also helps us with consistency. So there's a lot of studies out there that showing that contouring is not really something that people are very good at. If I draw a parotid and you draw a parotid, it's not going to be the same, right? They'll probably both be reasonable, but it's not going to be the same. And so that's true of lots of different things. This is just an example for the heart contour, where the heart finishes superiorly is something that people often have some variability in. And the AI, however, is extremely consistent. So AI helps us with timing and workflow, also helps us with consistency and quality. And what that means is you can contour all sorts of things that you didn't used to contour. And so this is just an example. These are contours that are available in our own. We're not really using them clinically, but they're available clinically, mostly for research purposes. And this is all of the different lymph nodes and all different swallowing and different structures, most of which, quite honestly, as a physicist, I don't know the names of, but there's all these different structures which are now available for doing things like dose response studies and things like that, which would have been impossible before. So that's the contouring. Now planning, another test. Which one of these was generated by the computer? So head and neck plan, we're treating that red shaded area, which is the computer. This side? Right. Yeah, you guys are good. So the one on the left is the actual clinical plan that was used to treat the patient a few years ago. The one on the right was generated automatically. When we showed these to the radiation oncologist, they had a slight preference for the one on the right because there's a little bit less spread of the dose. But the message again is that it's basically the same. So there's no, the one on the left is acceptable, so is the one on the right. But it's really, the planning is here. We can do all of this now. In terms of putting these tools into our own clinic, we use the contouring and some of the planning tools for about 350 patients a month. And when I looked a couple of months ago, we'd use these tools for about 16,000 patients so far. So the fact that we've put them in there and they're still being used is probably a better measure of the fact that the doctors like them than any sort of data I can give you. And then on the right-hand side, what you can see here is this web-based tool that I'll talk about at the end, which we've created to try and take these tools that we're using in our own clinic and make them available elsewhere to people who wouldn't have access otherwise. And there's also lots of commercial solutions. So if you go to any of the radiation oncology meetings now, there's dozens of companies offering these sorts of tools. So auto planning also saves you time. This is data from, this is for prostate planning, data from Princess Margaret in Toronto, hospital in Toronto, where the top section is showing their timing study that they did when they had human-generated plans. So the brown line is the time taken to do the contouring, and then the yellowy line is how long it took them to do the contouring plus the plan. And then they introduced automatic planning, and you can see that the planning time goes right down, but you're still at sort of 27 hours from start to finish because you're still doing the contouring by hand. And once you've done the contouring, I then pass it, you pass it to the next person. They don't start it immediately. They're not taking all of that time to do the plan. it sits on their desk because they're doing something else, right? They're doing somebody else's plan. And so if you try and sort of think of our traditional workflows where the contouring is one group, one person does that and somebody else does the planning, you're not really going to make much impact on the time between the CT scan and the treatment and the actual start of the treatment. So what you really need to do is combine everything, and you can do that now because if you think AI can do the contouring, AI can also do the planning. So why have somebody in the middle? Why not just compress it and push it together? Which brings me to the next test. Which of these was generated by the computer? Left? Why do you say left? Okay. Oh, okay. Well, you're right, but they're supposed to be acceptable. Both supposed to be acceptable. so good choice though. I like it. So the one on the left was generated by the computer, but the difference between this and what I was showing before is that for this particular case, everything was done by the computer. So the doctor said, this is my prescription, and please treat the prostate and the seminal vesicles. And that's all they had to do. They sat back and get this result with no intervention, so no human time involved. So that's a mass, and you know that if you think of the time that saved, and as you said, you like the plan, so the quality is there too. So that's good. Here's another one, a little bit smaller. This is cervical cancer. I'm going to stare at you now because you get left again. Thank goodness you guys got one wrong. So this is, but the point is the same, right? This is the same thing. So in this case, this is our tool that we have where the physician said, I want to treat the cervix and the lymph nodes. This is the dose. And then all of the contouring of the primary CTV, the pelvic nodes and ITV and all this sort of stuff, plus the plan was generated automatically without anybody having to do anything. And the point, of course, is that the quality is the same as if the person had been there to do it. So where does that bring us? It brings us to this point where once you take the CT, we're not quite there now today, but we're very close, where we've then got all of the contouring and the planning can happen automatically. And then we've still got a lot of approvals and things that happen at the end before we treat. And so that gives us all these benefits that potentially in terms of efficiency. So we can save hours of people time in preparing the contours and the plans and the fusions and all this sort of stuff. We've got less handoffs. So, you know, if I do the contouring and then I pass something to somebody else to do the plan, there's a risk that I don't quite communicate properly what I'm trying to achieve. So, you know, maybe you were distracted and weren't listening, or maybe I forgot to tell you something, but there's a risk there that if you compress everything together, you can argue that that may reduce the risk. There's also, because there's a lot of data showing that different people in different institutions plan things differently, you know, there's a lot of variability. So if I'm the patient and I get treated at this hospital versus that hospital, the treatment might be quite different, even though it's still me. So that, you know, in a way that doesn't make much sense. You want to be treated the best way possible wherever you go. And then there's also various gains that you get in terms of research and data science and understand. Just imagine if wherever you get treated, you got treated the same and it was always a high quality plan, then we could really learn something about like dose response, toxicity and things like that, which is quite difficult right now because of the variations from institution to institution. And this is my reminder that there's still people. So you know, like I said at the beginning, people are still the key component here. And so you've still got all of these different people, but what's happened is now you've got this sort of like people desert, if you like, in the middle where there aren't any. And so that's something that we really need to consider when we're looking at our workflows. This slide is just here to make a final point that, you know, when I talk about here, I'm saying we're going to start with the CT and then we won't have anybody needing to do anything until we get to the final plan. But there is a lot of work out there, not us, but a lot of other groups are looking at what happens if you say, right, we don't need the conventional planning CT anymore. We're going to take the diagnostic images. We're going to then automatically generate contours and plan, and then use like adaptive radiation therapy or some sort of immediate contouring and planning on the machine. You can completely miss out the planning CT. And I think that's really that will really help us with workflows and getting patients moved through the system. This is just work from a Chinese group using the United Imaging device. So if you I've given you this sort of rose-tinted glasses look at what AI can do. So I'm saying, oh, the contouring is going to be amazing, the planning is going to be amazing. That's great. But when you do all of this, what additional risk do we introduce? One of the things that keeps me awake, and I'm sure it's the same for most of you, you wake up and you think, did I do that quite right for that patient? What did I do wrong? And that's the sort of thing that we're going to have to change some of our processes once we start adding AI, and AI is coming for sure. Okay. Which one of these was generated by the computer? Head and neck. Right? Right? Most people saying right. Right. So the one on the left is a manual plan, and it's a little bit difficult, but you can just about you can see the hot spots, and you can see how they struggled with the IMRT because the tumor is so close to the cord, and so they've really struggled to keep the cord dose down, but they managed. The one on the right is a dose prediction by a deep learning engine that predicts what the plan should look like. And what you can see, it predicted that the dose to the cord, max dose, would be 57 gray. And as a human, it's just not going to happen, right? We know, we're so fundamentally trained that, it's either 45 or 50, but it's not 57 that you would accept. The computer didn't know that. And the reason it didn't know that was because this particular model was trained on a lot of head and neck plans from our institution. We tend not to have these big tumors that come that close to the core. It's an unusual case for us. So it didn't know, unlike a human, it didn't know that you shouldn't do 57 gray to the core. Nobody had told it that. And so so computers, although they're very good, the AI can really give you good results, they do make mistakes. This is the point here. And so we really need to think about our quality assurance model. In radiation oncology, we talk a lot about this sort of Swiss cheese model, where we've got lots of safety barriers in the way, so that if we accept that people make mistakes, but we've got lots of people in the way, these safety barriers, to try and stop those mistakes getting as far as the patient. And occasionally something will get through to the patient, but that's something that's got through these gaps in the Swiss cheese model. Because I'm checking a plan, I won't catch everything necessarily. There's a chance I'll miss something, but somebody else is looking somewhere else, and someone else is looking somewhere else. And the risk with AI, in the way that I've sort of expressed it here, is you're taking people out of the loop. And so if you take people out of the loop, you might reduce some risk because there's less people to make mistakes, but you also increase risk because there's less people to catch mistakes. So you're doing a good thing and a bad thing at the same time. You really need to think about that. And the other thing is that AI will pretty much always give you an answer. So if you go back to this, it hadn't seen a case like this before, but it gave you an answer. And so you need somebody at the end here to really check and look. And that's one of the points I want to make today, is that some of those time savings that you make in the middle of the process need to be invested at the end of the process to make sure that the AI did do what you wanted it to do. And so in this case, it was given a tumor that was closer to the core than it was used to. And so, but there's also other things that could be given to it that it's just not used to. So there's just some examples here, like the hip implants. If you give that to a human person to do the contouring of the planning, they'll say, oh yeah, it's hip implants, and they'll maybe contour a little bit differently, or it's slowly going down. Or, and when you do the plan, you'll have different beam arrangements, you'll do some overrides of the density and stuff like that. But the AI may not know that if it hasn't been trained in that way. And the middle one is a breast implant, where it tried to draw the breast structure, didn't really understand, thank you, and didn't really understand the breast implant. And then on the right-hand side is a cervical cancer case where there's a lot of compacted material in the intestines that it hadn't seen before, and that can cause trouble. Here's another example. This is a tool that we developed. It's not in use in the clinic, but the idea is that you tell it what vertebral body you want to treat. So for us, when we're treating palliative vertebral bodies, we'll treat plus or minus a vertebral body on each side for palliation. And so in this case, you said to the AI, please treat L1 with one vertebral body on each side. And you can see, if you look at what it's drawn, it's missed a vertebral body out. And so what happened was it drew L1 correctly, which was what we wanted it to treat. But this patient actually had a T13. So, you know, which is not normal, of course, but it's not that unusual either. But it got very confused by this extra vertebral body because that wasn't really how it had been trained. And so it drew L1. It drew what it thought was T12. It was actually T13, but at least it drew something. But then it got confused. And so it drew the next, it missed one out entirely, and then drew the next vertebral body, and then generated the plan. Plan looked like this. So this is, you know, the AI didn't, you know, there's no way a human would make that mistake. I mean, we miscount vertebral bodies for sure, but you wouldn't create a plan that looks like that. AI will do things that you don't expect. And that's another point that you need to think about, because we're very attuned when we're reviewing a plan to the mistakes that residents can make, for example. You know, everyone can make mistakes, but we know the sort of mistakes that people make. We don't necessarily know the sort of mistakes that computers can make. So that brings me to these principles for deployment of AI tools. So let's assume you're getting some sort of AI tool that's being provided by a vendor like Elekta or Varian or whoever, it doesn't matter. So you've got some level of expectation that they're going to be fairly robust in terms of input and giving you something good on the out, you know, because they've been through some sort of regulatory testing, so FDA or some sort of equivalent to that, CE maybe. And so you have an expectation as a user that that's going to be reasonable, but it's really difficult for the vendors to properly, comprehensively assess the robustness of their tools. And I'll talk about why in a minute. So really the robustness, though, is the responsibility of the vendor for sure, but also of us, the user. You know, we're going to take that particular tool, we're going to put it into our own clinical practice. And so we then have to take responsibility for that and look at that. And ideally, we would be able to learn from the vendor what tests they've done so that we can augment that with our own tests, with our own patients. But often that data is just not shared from the vendors. So we have to really just assume the worst case scenario and test everything. And then the final point is that robustness needs to be applied not just to that particular AI software, but to your entire process. So the AI tool is going to generate contours and plans or whatever it's generating, but you've got to think, how does that fit into our process? Because our process has been developed based on sort of decades of clinical experience and the fact that contouring and planning are separate and people are doing it, not computers, all this sort of stuff. So we have to then apply the robustness tests to the entire process that we have in the clinic. So what can you expect from the vendor? So you can expect some sort of overall robustness. You can expect them to have properly looked at things like cybersecurity and usability and things like that. They'll give you some sort of indication of what's the intended use. So, you know, is it for CT images or MR images? Maybe something to do with slice spacing and things like that. Like you can't use it on more than 5mm slice spacing or something along those lines. And also some of the limitations that they have just determined during their own testing. So maybe something to do with image protocols or artifacts like the hip implants that I showed a few slides ago, and maybe something to do with patient characteristics if that came up during their testing. So like collapsed lung or something to do with surgery and things like that. But they will have tested on a group of patients that may not be the same as your patients. You know, so like for example, when we did our testing of our system, we went through the FDA. The FDA really only cares about patients in the United States because that, you know, it's the American government organization. And so, you know, that hasn't been tested on patients from elsewhere very much necessarily. So you have to really think about that. But even the limitations that they do have, it'll be in the manual. This is my AI generated manual, by the way, but it's covered in dust because no one reads manuals, right? You know, if you're going to go and use your auto contouring tool, you're not going to go and read the manual and look at the limitations first. You're going to, or maybe you just assume the physicist did that. But you know, you've got to really think that about that. So what are the differences that can really affect this? So we have found um, that differences in patient populations tend not to be a major factor, to be honest. And so for example, this is an example here for breast where we've got this tool that does automatic contouring for breast and all the lymph nodes and organs at risk, and then generates different types of breast plan depending on what was asked for. So like either just tangents and superclav or VMAT, all the different combinations that there are out there. And then we've tested that on patients from a lot of different countries, and we found that its robustness doesn't really change from population to population. So it doesn't matter if your patients are from Iran or from the United States or Jordan or South Africa. It works with basically the same level of robustness. So differences in patient populations don't really seem to be a major issue. There are some exceptions, but overall that's true. But what we found are major issues for the robustness of these AI tools are differences in clinical practice. So, you know, I mentioned earlier, and I mean, everybody's aware of this, different places treat patients differently. And so when places test their tool, they will test it with the clinical practice that they're familiar with, or at least that they've been told about. But what I've found, what always seems to happen is that you've tested with a variety of different situations. Almost always there will be somebody who is doing stuff a little bit differently. And so the tool is then considered not to be as robust. And so this is just an example here where we have this cervical cancer or auto contouring and planning module that we created. And in our practice, all of the main CTVs are treated to the same dose. But then we took it to somewhere where they were treating the primary CTV, they were treating to 50 gray, and then the pelvic lymph nodes, they were treating to 45. And that was just not a situation that we'd had in any of the test patients that we'd had from any of the North American centers. And so that then there was a bug in the AI that didn't show up until you had this different combination of prescriptions that it hadn't seen before. So although it looked robust before, suddenly it seems like it's not robust. And there's lots of different examples of that where things like clinical opinion, your treatment goals, your acceptable compromises. So like the compromises between coverage versus hotspots and things like that, they vary widely between institutions. Prescription, field shapes. The figure on the right is for whole brain. We treat quite a lot of whole brain still at MD Anderson, and we created an automatic tool to simulate the fields that were done manually, and that's what you can see in the top right. You can just about make out the MLCs in blue. And so that was quite popular in our own institution. Then we took it to our friends in London and said, look, we've got this tool. What do you think? And they were like, what the hell is that? They're not very polite over there. So they know we can't treat patients that way. They don't, because they don't create the fields that doesn't look anything like what they do. They treat fields that look at the bottom right, which they're both treating the brain, but they both look differently. And you know, neither group would accept the other group's approach. So we had to create another approach, which is fine. And then on the bottom left is contouring. So this is from a group in Europe where they wanted to look at how the contouring quality varied when you took it to different patient populations. So they took their contouring tool and they used it in China, the Netherlands, and South Korea, and on the different patient populations, and then had those contours reviewed by local physicians from those 3 different countries. And what they found was not that the contouring quality was affected by the patient population, but the physician's review of the contours varied. So it was more to do with how the clinical teams were trained in their backgrounds than it was anything to do with the patients themselves. And it's just some more examples. On the left is contouring for pediatrics. So we have an automatic tool for contouring and then creating the treatment plan for CSI, for pediatric patients. And we developed this, and then we got the contours and took them. You can't quite read it, but this is just different structures here with different reviews by different physicians. And each group is a different physician. And we showed to two physicians in different institutions, one in our hospital, one in South Africa, and they both seemed to quite like most of the contours. Then we showed to a third physician at a different institution, and they really didn't like the spinal canal contour, because there was something to do with the spinal nerve roots not being covered, which two of the physicians cared about, and one of the physicians didn't care about or didn't think was important. And so that just those differences mean that a tool that showed as being robust when showed to this group of people becomes not robust just because of different clinical practices. So it's something you just have to be aware that that's going to happen. And then the other thing that can happen is that clinical approaches change over time. So something that was robust a couple of years ago and considered okay is not necessarily okay now. And so this is an example of lymph node families drawn automatically. And so we developed a tool to do this a few years ago using a little bit older data, but from our institution. We then put that out we got the physicians at that time to review it, and they loved it. But by the time we went through all the processes to put it into the clinic, they then hated it. And what had happened, they changed how they were drawing these lymph node groupings and actually were drawing much smaller structures. And you can see here, there's two contours for each structure. The larger one is the old one, and the thinner one is the new. And so the larger one, which we'd spent, it's basically someone's PhD to develop that, was no longer useful because they weren't drawing that in that way anymore, because clinical practice had just changed, and that can happen. So all of that added together is really just trying to say that it's very difficult for any of the developers, with developers and users in our case, but it could be from one of the commercial vendors. It's very difficult for them to create something that's robust to they don't know about your particular patients and your particular clinical practice. So when you get something, you have to consider that of course, they're always going to say that their thing is great, and you never believe it, but you've got to really think about the safety when you put that into your own clinic. So what can we expect from ourselves? So it would be great if we knew what risk evaluations have been done by the vendors, but you might have an idea, but you don't really know, to be honest. And so we really need to think about workflows and develop our own workflows so that we can be prepared for this AI. And what I'm showing here is, this is just all of the different steps that are involved in the preparation of a treatment plan. And even when I'm saying, oh, AI is going to take over all these tasks and everything, there's still a lot of things that humans do, right? So the people are involved in so many parts of this process, and AI is just a tool, but it means we really need to look at the interaction between the people and the AI when we're looking at our workflows. So what this figure is showing is some of the AI specific sources of risk. So once, there's lots of sources of risk in radiation therapy. It's inherently risky, and we do everything we can to manage that risk. Adding AI introduces new risks. And one is operator error. So there are, users can still make mistakes, and some of those become worse when AI is involved, and I'll talk about that. There's off-label use. So an example of off-label use might be if you've got some sort of auto-contouring that was developed on adults and you apply it to pediatric cases. And sure, it might work, but there's no guarantee it's going to work. It might do something that you didn't expect. You have to be ready for that. The software error, I think, is self-explanatory. There's automation bias, which we've seen in our own practice, when the auto contouring that we have today is so much better than the auto contouring we had 5 years ago. So 5 years ago, if you ran the auto contouring, often people would just delete the answer and start from scratch, or maybe but they always knew they'd have to, at a minimum, make some edits. You'd never just use it. Now that's not the case. Now I would say probably 90% of contours are fine just the way they are. And so, but what does that mean? It means that we start to become very reliant on it, and maybe we don't check it as carefully, and that's what automation bias is. You can skip that one. So So automation bias is it's like complacency. So they're all saying, oh, the auto contours are always right. So what do you do about that? You have to have like your quality management plan that describes your workflow has to account for that and have things in it like required second checks, checklists, and things like that. Process monitoring, which I'll talk about in the next slide. And then this can also lead to over reliance, which is like a loss of skills that happen because you're not having to do these things anymore. So for us, an obvious example in our clinic of over reliance is like if you're doing a whole brain, and we used to do them all by hand, and so you knew that brains are pretty much always 15 centimeters across, and and this sort of thing, and you knew that if you were going to treat 150 centigrade from each side, they're probably going to have about 160 165 mu. People don't know that anymore. They've forgotten because they don't do it anymore. They just press the calculate button. And so we've got to really think about training to keep maintaining those skills so that we still understand what's going on behind the scenes. And this is one of the projects that we have ongoing that is definitely something I'm interested in collaborating. I know you have 60 residents, so this is something that would be interesting, perhaps. This is a flight simulator to train people in understanding what a good treatment plan looks like. And so it's using AI to simulate the sort of interaction between the doctor and the treatment planner. So in this case, they were given a plan, and the doctor, you literally say to it, please reduce the parotid dose in this case. And it does what the planner would have done. This isn't a real plan. It's just showing you what the plan would look like. And so you don't have to say it, and then the planner goes away and comes back in 2 hours' time and says, here's the new one, what do you think? It's almost instantaneous. And so you can go through this loop and look at lots of plans very quickly. And we're hoping that that will help with training. That's a comment that our own residents have, that they don't get to see enough of the finished plans and sort of have that interaction. And so we're looking at that. So there's ways to overcome these things. Something else you need to think about is process monitoring. So when you start introducing these tools into your clinic, how are they being used? And it's often a little bit opaque unless you really look at the monitoring. And so what you can see here as an example, this is from our own institution where we looked at the one on the left is DSC, stands for dissimilarity coefficient. It's just a measure of overlap of your automatic contours, your edited contours. So a 1 would mean there's no editing, and a 0 would mean it was completely edited and changed. And then each of these different the different colors are different dosimetrists who've used this. And you can see, what you can see is different dosimetrists are doing different amount of editing for these contours. And so the first dosimetrist, you can see that's pretty much all entirely 1, means they're not really editing anything. The second one is down at sort of 0.9. They're editing everything a little bit. And so there's different people are using these tools in different ways. It doesn't necessarily say it's good or bad, but it shows that you don't have consistency in your practice, and something you should think about. And then the figure on the right-hand side is here, the y-axis, APL is added path length. It's another measure of how much editing you did for a structure. And this is for one person over time. And you can see that over time, they're doing less and less edits. So it doesn't tell you why, it doesn't tell you if it's good or bad, but it does, they've given up, they don't care anymore? Or is it because they've realized that you don't need to do those edits? It doesn't tell you, but it does tell you that maybe you should look at that because something has changed in your practice that could impact the quality of the plans that are coming out. Something else we need to think about is attention tunneling. So that's how do you look at the plan? So an example of attention tunneling is where you really focus on the DVH of your structures and you forget to look at the structures and the dose distribution themselves. And so that can happen, especially if you're doing like adaptive radiation therapy, if you're pushed for time. And we've seen this, like where we had a case, didn't reach the patient, but we had a case where the auto contouring for the optic nerve wasn't correct. The DVH looked great, by the way. And so everyone had looked at the DVH and said, yeah, this is amazing, but no one had looked at until like the very last minute, we got caught in the final checks, but they hadn't looked at the actual contour. They're so focused on the DVH. And so the way to sort of mitigate that is to have cross-disciplinary reviews and constant sort of risk-based training and monitoring. And then the other thing here is data overload. So now we can do all these things. You run the risk of just giving the physicians too much. So that's the same movie that I showed at the beginning, where then I was saying, look, it's great. We can create all these contours. Now the message is the opposite of that. It's like, oh my God, there's all these contours. And so if you show all of these contours, what are you really going to do with that information? And you're likely to miss something. There's various ways to mitigate a lot of these. So we've shown, for example, that checklists can really help. So we use checklists for our routine physics checks of plans. Here we showed that if you, like I've shown a few times, AI does things that you don't expect. We already know what errors humans make because we've been doing this for years. We don't know what errors AI makes. It can do unusual things. And so you might have to have additional items in your checklist for reviewing the plan so that you can catch some of these things. And so this was just work that we did where we showed that an AI specific checklist can help you reduce risk, catch errors, and stop things getting through to your patients. Skip that one. So just a few things to think about just towards the end. So robustness, we do expect that the vendors will give us robust software, but robustness, like I said, is difficult for them to really assess. So they're going to try, and the regulatory agencies are trying to make them robust, but they may not be robust, partly to your patient populations, more likely to your own clinical scenarios and workflows. So we have to really think about that. We have to understand errors. It's important for us to understand errors and encourage people to publish things that go wrong. All the papers that you read out there about AI are telling you how amazing it is. People often gloss over the things that can go wrong, and those are the things we really care about in the clinic. Okay, so that's the risk part. I want to spend the next few minutes, not very long, just talking about the work that we have specifically, and maybe that can sort of interest people in some potential collaborations moving forwards. And so we started about 10 years ago now, we started developing these tools for our own clinic, and then also developing a way of making these tools available to clinics globally. And the reasons for doing this was just that there's so many places that don't have the same level of access as we have we have lots of insurance problems, mind, but we do have lots of access. And so we built this web page, which anybody can access the front of the web page at least, and it can do auto contouring and auto planning for a relatively limited number of cancer types. So it can work for cervical cancer, post mastectomy breast, head and neck, and whole brain. So that's all it can do clinically right now. The best offering I would say is cervical cancer, where it has 3 different offerings. It can give bony landmark-based full-field box, soft tissue-based full-field box, and then VMAT. And then the others are a bit more restricted, but for chest wall, it does tangents and superclav and field-in-field and things like that. And then for head and neck, it's the contouring and VMAT planning. It's been through FDA approval. It has also been through a lot of international testing. So these are just results here. I know they're a little bit difficult to see, but for everything that it does, we tested on 75 patients, and we had at least 3 physicians from different institutions look at the results. Total of 31 radiation oncologists, 16 institutions across the world. And in most cases, the acceptability, which means the sort of use as is rates, are sort of at the 80 to 90%, which means that 80 to 90% of the patients that are put through the system, you can use the results as they are. And then the 10 to 20% that's left, you have to do some editing or maybe start from scratch because it's not what you want. But it should be an effective time saver at least. Here's some results from Tanzania, where they tested our system on their own patients. They did soft tissue planning for cervical cancer. They had 2 radiation oncologists, and they've had 97% use as is, and it took them 6 minutes to review. And there was just one case that wasn't used as is, and that was a case where the CT scan didn't go superior enough, and so the AI couldn't figure out the anatomy and just didn't give an answer. But for all the other cases, they consider them ready for clinical use. And so where are we in terms of clinical use outside of our own hospital? MD Anderson has committed to provide this for free. So that's the idea. Like I said earlier, we're treating about 350 patients a month in our own clinic with these tools. It's approved by the FDA, and we've got legal approval, and we've launched in South Africa. So we launched last year, and we're now in 6 hospitals, of which 4 are somewhat routinely using it. 1 is using it pretty much for all of their cervical cancer patients. And we're learning a lot through that process. And we're now looking at whether we could deploy it in Indonesia. Basically, the first thing we've got to do is make sure we don't break any laws. We don't want to get in trouble. So that's what we're going through now. And then for version 2, lots of prototypes. So when we went through the FDA process, we had to freeze the system so that we could do all the testing and what have you. But during that time, we've been developing other prototypes. So we have prostate cancer, we have more advanced work for cervical cancer, intact breast, pediatrics, and a lot of auto contouring, and then SFRT we're working on, things like that. So these are all, I would say, all of these are places that we really want collaborations on, because whatever's important to you is what makes it important to us. And then in terms of sort of what sorts of things can we do together, I sort of put these together in order, somewhat order of difficultness, if you like, not technical difficultness, but collaboration difficultness. So the easiest things are to take tools that we already have that we developed on our patients and see if they work with your patients and your clinical workflows and what have you. But then, the next level up is to say, well, what's important here? Are there situations or patient or cancer types that you have that we don't see very much of, that we could work together that would really help with your clinic? And so those are the sorts of things that I think those require a closer collaboration, more interesting and more fun, I think. But that, and especially if there's things that you think the vendors are unlikely to develop. So I think a good example of that is pediatric work, actually, because there's just not enough of, vendors are going to focus on things like prostate, because there's so much prostate cancer. They're focusing less on this other stuff. Okay, so that's my last slide. Thank you very much for inviting me. Thank you for listening. And I'm happy to take any questions. That's it.
Thank you for the opportunity. I would like to ask, as one of the developer of the AI contouring software, do you find any difference in contour modeling when you do the training between the European-based guideline and American-based guideline? I'm talking about the ASTRO guideline and, for example, and the RTOG guideline, and how you deal with that. Thank you.
So yeah, that's actually a really good question. So when we started doing this, I didn't totally appreciate the differences that you've just mentioned, and we just used our clinical data to train the models. And what I've learned is the challenge there is clinical, when you're drawing for your particular patient, you're following a protocol, but you're also making changes because it's your particular patient. And a lot of the nuances that become sort of blurred out when you do the training. And so you end up with a model that actually is not very good. And so what you need to do is, it's much better if you can get data that's drawn specifically for training. So not just say, oh, we've got thousands of patients, we'll train the data, but to take data that's created specifically. And that's what we've done. We've done that now for cervical cancer and for head and neck and for breast. And and for prostate to some degree. So, and we're starting to go back and do that for everything because we've found that's the only way. And so when you get to where there's distinct standards that are different in some way, you've really just got to have two different models. Because the AI doesn't know which one you want, right? And but you can't. That's not going to come out of any sort of clinical data. We're going to have to create training sets and create models for those. Yeah, so so what we did for cervix and for head and neck was we had a radiologist go through and contour 100 patients of each, like very carefully following the protocols. And because and it looks different. Once you add margins and everything, the final result is sort of the same. So I don't think there's necessarily much impact on the patient, but the differences. But when you look at them, they do look quite different. And so you have to get some data, especially someone has to curate the data. Data curation is quite honestly, making the models is relatively easy. It's the data that's the most difficult thing. Yeah.
So thanks, Lawrence. All the tools are very great. But one thing, I think one other part where this can help a lot actually too. The first one, what I can think of is using AI to help us for verification purpose. When we want to treat, especially like prostate, there's a possibility of movement. Sometimes we rely on people to look at the image, and with this tool it can be more consistent. We can make sure that what we plan is being treated even though there's some movement. And the second thing that I think that can also help is as more and more LINAC have adaptive capability, why we keep treating a large field. If there's a movement, every day we can shift with this, and we will lower the side effect. I know that takes time to prove it clinically, but with this become possible.
I 100% agree with both of those. And I think why do we not do an adaptive treatment every day? It's because it's so much work. There's a lot of work, there's a lot of effort, and there's also a lot of risk, right? Because every time you change something, you might make a mistake. But once you can do this so much easier, then why not just do it? And we're not there yet, but you can definitely see that on the horizon. And like an example of that is like patient-specific QA that we do. Like I know you guys have a halcyon. Once you've got the halcyon, you press the button and it does it. It's so much easier than before. So all the arguments against doing something really change. So I think that will definitely change. And I think pushing it even further, like I gave that quick example about the United Imaging LINAC that they have, where they've been trying to do a sort of CT, a plan without using a CT, the initial planning CT. I think that's going to go that way too, because you can do things that you couldn't do before. And the verification is just an extension of that, really. But you reminded me of something else that I didn't talk about, which is the use of AI to verify AI. And so a lot of the checks that we do, like if you give me a plan to check, I spend time going through the contours, making sure they look correct, going through the plan, making sure it looks correct. Well, I don't need to do that. An AI can do that because an AI can look at the contours and tell you if they're correct, probably better than I can. And so those tools, I think, are going to be built in at some point into either into the vendor, like into Eclipse or Monaco or what have you, or as a separate module or something. But I think there's a lot of the things that like with a lot of the things that we do to check a plan is okay, we're still gonna have to do them, but maybe the AI can help us out there, which would be really nice. So yeah, lots of changes. Yeah.
Thank you for the chance. I want to ask about maybe a little technical in here. When we discuss, you ever told me that the surface test is good for checking the delineation of the contouring AI. What I want to ask is there any cutoff that you use for the surface dice for the thinking that this is good enough first? And the second is when we try to making AI working our case, do you have a different mindset when they are trying to making the AI planning or dealing for the cervix or head and neck? Example, if in head and neck, I believe that there is a priority one checklist that I think this is okay. And for the cervix, it's not be done with this way of thinking. So do you make it a specific way, different way of checklist, thinking the priority?
Yeah.
Thank you.
So the first question is about surface dice, right? So, and like verifying the quality of the contour. Yeah. So we use surface. I mean, I just mentioned dice briefly, but there's lots of different metrics. We do use surface dice as well. It really, the challenge is that none of these geometric metrics really tell you about the quality of the contour. So if you get like a dice or surface dice of 0.9, for example, and 0.9, you think, oh, that's pretty good. But the thing is, 0.9 can actually be quite bad as well. So it's usually pretty good, but not always. And the same with, like, by the time you get down to like 0.3 or 0.4, it's definitely just bad. There's no question about it. But it's quite difficult to know from the geometric metrics if it's a good contour. So what we do, we use those as well, but then we supplement that with physician review because a person can still think through the things that are wrong that the computer can't. And then we add on top of that, we only just started doing this relatively recently, but on top of that, we've added the effect on the dose, because really what we care about is the dose that gets to the patient, not some contour that we drew. So we're trying to assess contour quality in terms of the effect on the dose, and I think that's where we're going to be within the next year, is really using dose indices instead of geometric indices. And then for the cervix versus the head and neck, you're asking like about how do we evaluate the quality of the plan?
Yeah, so the quality of if you planning like cervix, I believe it is good enough. If I maybe in the head and neck you try to give more concern in the spinal cord, and I'm okay with that. I'm not okay with this, or it's because it is I you see the deviates or the coverage.
Yeah, so I mean we basically treat them the same as the treatment planner would, in that we consider them to be separate, but we do, beam arrangements, for example, are pretty standard between all of the sites for VMAT at least. Yeah, I mean, we just consider them separately. I don't know. Yeah, you can't really take one and apply it straight to the other for sure. Not yet.
Thank you.
Laurence, I have a question about a point you brought up earlier. It was about complacency. Personally, that I find that quite relevant in processes without AI as well. When I first became a consultant, this was a real experience. I was very thorough. I looked at everything that the residents did. with 0% trust in whatever they did.
Yeah.
Immediately, less than a year after that, I became totally complacent and signed things without checking. And then there was an incident that happened. It was captured in our grand round, our peer review round, and that was quite humiliating. And I decreased my trust level. So I imagine that the same thing happens in our interaction with AI systems. But you highlighted something important, that the mistakes that residents commonly do is different with possible mistakes that AI does. It's more unpredictable. And I was wondering, there are two different ways that people train their AI software. First is using local protocol, and the other one is just accepting a pre-trained data, which hopefully comes from expert consensus. Both of them might have their own issues when this training data set comes from the local data. You mentioned something about MD Anderson's change in protocols. We have also seen from Dini and Stephen's small study that with so many variations in the local practice, the data becomes unusable. But there was also this experience from IEA ELISA study, because there was an expert consensus contour that was done, and the participants respected the experts. They kind of become reluctant in editing the results.
Mm-hmm.
So what do you think about these two things? Thank you.
Yeah, so in terms of where the training data comes from, do you use like the vendor will give you they've trained in some fashion with some data? We found, even at least in our experience, we found that the vendor supplied contours don't quite match what our doctors want, and so we've had to retrain ourselves, and that's for us that's not a terrible task to have to do, because we have the infrastructure to do that. We've been doing that. I'm really, yeah, there are groups out there that take the viewpoint that you should almost you should have a model for each physician, because everybody has a slightly different style to some degree, and that you should do that. Personally, I'm a little offended by that approach in that how great would it be if I'm the patient and you create the contours in the plan, or somebody else creates the contours in the plan, it's always the same high quality and the same. I think that's, I'm ignoring patient population differences for a second, but just that would be so great. And I really think that's where we should head. And I think some of the editing that happens because we can edit, not because we have to edit, and so I'm hoping we can avoid making all these local models. But the counter to that, this is just a really difficult question that I've been thinking about for years and don't have a proper answer. But the counter for that is, if we give you a model that you don't like, you just won't use it. So maybe we have to make a model for you. It's really difficult. So I think there's not really a good answer to that. I have definitely found there's I don't know if it's cultural or just resource differences in how people approach this question. So at Anderson, people always edit everything, but they've got lots of resources. There's lots of doctors, there's lots of planners. So if you say you don't like it, there's lots of stuff, but there's lots of people around. When in South Africa, there's much less of that, and they're much more, oh yeah, it looks great, get on with it. So I think, and even like the one hospital that uses our cervical cancer contouring and planning a lot, they don't edit the sort of the bulk of, they actually like to treat, they don't treat as superiorly as our contours go. So that's the edit that they make, is they delete slices, but they don't really make much edits in the bulk of the contours. They say that looks, it's adequate for fit for purpose, I guess is what you would say. So there might just be some place there's more of a realism, perhaps. It's difficult to know. It's a very difficult question. But I'm hoping it would be so amazing if we could say, you know, it didn't matter if I came to this hospital or my hospital or a hospital in somewhere, some rural region, and I got the same treatment. That's what I feel like. That's what we should be aiming for. Not quite answering your question, but that's, yeah, it's a difficult one. Yeah. Cool. Thanks very much for listening.
Is there any other question from anybody? So if there is no other question, maybe we can close this lecture. Thank you very much, Mr. Laurence, for a very comprehensive lecture. Hopefully this topic can teach us a lesson and hopefully we can help us in the future. Thank you very much. Let's close this lecture.
Thank you. Oh, yes, that would be great. Oops.
After this, there will be a photo session. Please, for the participant and a doctor, please, we can come in front to we take a photo together. Please, for the participant, we can go to the front to take a photo. Let's go to front to take a photo. Please, for the all semua atau langsung semua atau please, all of you, all of participant. Bapak, Ibu, maju ke depan, mau kita ambil foto. Ayo, pelan-pelan. Dengan